Today we'll discuss genital prolapse and stress incontinence. All right. So to understand, so genital prolapse. So to understand genital prolapse, you must know the anatomy of pelvic diaphragm. So let's first understand the pelvic diaphragm. Then we'll wait. It's not recording. Okay. So let's first understand the pelvic diaphragm, the pelvic floor, the anatomy. And I request you take a pen and a paper so that draw it me so that you can have better imagination. And then we'll try to understand what is genital prolapse and why there is stress incontinence. So when we say pelvic diaphragm or pelvic floor or pelvic diaphragm, pelvic floor or pelvic diaphragm, wait. So pelvic floor or pelvic diaphragm, then there are two group of muscles which mainly form the pelvic floor. Okay, this is levator ani and coccygeus muscle. Levator ani and coccygeus muscle, they basically forms the pelvic floor, which is a gutter-like kind of thing. That's why it's called hammock type. It's a kind of gutter-like. Okay. So when you see from the top, it will be like gutter kind of things. When you hold your hands like this is the pelvic floor. The hand is your pelvic floor. So let's try to understand the anatomy now. So on the anterior side there is pubic symphysis. Okay, pubic symphysis on the anterior side, and on the posterior side there is a coccyx. There is the coccyx. Okay, so anterior side there is pubic symphysis and posterior side there is coccyx. Okay, so this is the whole pelvic cavity. So if we see from the first, you need to know the differentiate between the anatomy, other anatomy, that is like so this part is called false pelvis. Okay, first try to understand this part. On the top is called false pelvis. This is called false pelvis. Then this bottom part is called true pelvis. Then this part is called true pelvis. This part is called true pelvis. True pelvis. Okay. This part is called true pelvis. Then below this true pelvis is this here is the pelvic diaphragm. This part is called pelvic diaphragm. This part is called pelvic diaphragm. And below the pelvic diaphragm, this part is called perineum. This rest of the part is called, below part is called perineum. This part is called perineum. So we are concentrating today here in the pelvic diaphragm. So this is the false pelvis, then below true pelvis, then pelvic floor or pelvic diaphragm, which is a gutter kind of thing. And there below the pelvic diaphragm, all these muscles, these comes in the under perineum. Okay. So if we look at the pelvis, now pelvic brim, so anteriorly we have coccyx, anteriorly we have pubic symphysis, anteriorly, and posteriorly we have coccyx, posteriorly. So surrounded by, it is by obturator internus muscle. There is obturator internus muscle, it's surrounding here. Obturator internus muscle. Okay. So this blue is obturator internus muscle. And in what is in the pelvic cavity, we have here one from anterior side to posterior side, one urethral opening, then there's a vaginal opening, and then there's the anal opening. Okay, so this is for urethra, vagina, and anal opening. Alright, then let's make the bone then. So we are looking from the top. So we are looking the pelvic cavity from the top here. Okay, this is a top view. Okay, there is the urethral opening, then there is a vaginal opening, and there is the anal opening. So this anal opening with the coccyx, there is a raphe. Okay, there is a this is called anococcygeal raphe. This is important for the insertion of the pelvic muscles. Okay, this is called anococcygeal raphe. This is called anococcygeal raphe. Okay, anococcygeal raphe, this part between connecting the anus and connecting the rectum, actually connecting the rectum, we say the rectum, connecting the rectum with the coccyx. So anococcygeal or anal canal to the coccyx, anococcygeal raphe. So this part is anococcygeal raphe. Right? Now, most important muscles here is pubococcygeus. Okay, remember the name pubococcygeus because this muscle is very modified. It holds a lot of function. Okay, we'll discuss it. So pubococcygeus muscle. So this pubococcygeus means pubis to coccyx. There is one muscle here, and there is another muscle is ischiococcygeus, or you can also call as coccygeus, or ischiococcygeus. So as the name suggests, ischio. So this is the ischial iliac spine. So from the ischial iliac spine to coccyx, both sides, so from the ischial spine to the coccyx, both sides. So this muscle, that is ischiococcygeus, is not so well developed in human beings. Okay, it is more needed in the mammals where there is a tail. So that's why it's also called a tail muscles, because dogs need to control that movement of the tail. So to move movement of the tail, this ischiococcygeus is required. So in human beings, it is rather like a kind of vestigial muscle. Okay, you don't need much more. So we come to the pubococcygeus muscle here. So this pubococcygeus is a highly modified muscle because it holds all these organs. Alright, it holds all these organs. So let's start from the pubococcygeus muscle, means pubis to coccyx. So first it holds this. It gives a string of muscles and holds the urethra. It holds the urethra like a sling. So this is like urethra in lying down position, and it holds like a hook. So it forms the external sphincter of the urethra. Okay, so this is called sphincter urethra. So what is sphincter urethra? It is a modified muscle of pubococcygeus. It is a modified pubococcygeus muscle. Okay, so sphincter urethra. So this is called sphincter urethra. It is like a sling. It is holding the urethra. Okay, it is holding the urethra. So this is a modified version of modification of pubococcygeus muscle. So pubis to coccyx, pubococcygeus muscle. Then there is another sling coming up, and it holds the vagina. So it holds the vagina, and this is called as sphincter vaginalis. Okay, so first is this muscle is holding the urethra. This is called sphincter urethra. Next you got pubovaginalis. pubovaginalis. Okay, so sphincter urethra, pubovaginalis. These are all the modification of pubococcygeus muscle. Remember that. They are all modification of pubococcygeus muscle. Okay, we'll leave this anatomy when we will discuss the prolapse. So it's very important that you know these parts. So another sling is coming from here and holding the anal canal and the rectum. This is called puborectalis. So third is, this red is puborectalis. Puborectalis. So three different slings coming from the pubococcygeus muscle that arise from the pubococcygeus muscle. One is sphincter urethra. Second is pubovaginalis. Third is puborectalis. So all this urethra is held by the sphincter urethra and the pubo. This is the modification of pubococcygeus muscle. Then pubovaginalis is holding the vagina. All are their slings. Okay, they are slings. And puborectalis is holding the rectum and the anal canal. Now coming to the muscles. So iliococcygeus muscle, iliococcygeum from the ilium. It starts, okay, from the ilium. So from the ilium, and it joins this anococcygeal raphe, both sides. So this is called ilio, from the ilium to the coccyx. Okay, so iliococcygeus. And then the rest of the part is occupied by the pubococcygeus, okay, which is also joining this anorectal raphe. So this is the main bulk of pubococcygeus muscle, along with its three modifications. So this is pubococcygeus. So pubococcygeus plus iliococcygeus, they are called levator ani. They are called levator ani combinedly. One, this pubococcygeus and iliococcygeus, together we call it the levator ani. Okay, they are called levator ani. So when we say pelvic floor is formed by number 1, pubococcygeus, number 2, iliococcygeus, number 3, this is number 3, coccygeus muscle. Though it has not much function, but it is still forming a part of the pelvic floor. Okay, so this is pubococcygeus, then iliococcygeus, this is blue one, and this is anococcygeal or coccygeal. So, and these are all modification of pubococcygeus. Okay, so they form the pelvic floor. So this pelvic floor you can imagine. So when the fetal head goes from the and going towards the descent, and it's going to come out of the vagina, then it is where it is causing stress. It is causing stretch of which muscles? It is causing stretch of these muscles. So when these muscles, this muscle, and these muscles, they will be stretched. So there can be tear. Okay. So you can imagine if there is repeated pregnancies or multiple cases, there is always a chance of weakness of this pelvic group of muscles. So these muscles, this pelvic floor muscles, they are voluntary muscles which we can contract voluntarily. You can contract it voluntarily. That's why after pregnancy or after delivery, there is always a, nowadays is very much developed, it's called Kegels exercise. So in Kegels exercise, what a person they are asked to do, they are asked to contract these muscles, hold tight. So you can do this exercise even when you are sitting or anything. You can just hold the muscles for a long time, as much as you can, then release it. Again you hold it for a long time, release it. So that's a pelvic floor exercise. It treats all those kind of prolapse and other stress, incontinence, many things. Okay, so that is Kegels exercise. So when you say Kegels exercise, we are basically concerning with the pelvic floor muscles. Okay, so again, pelvic floor is formed by pubococcygeus, iliococcygeus and coccygeus. So they are together, they form the gutter. They form the gutter which is deep down here. Okay, which is deep down. So when the fetal head comes, so this is in a, we are looking at the from the top. So when the fetal head goes from the top and going inside the, now from the uterus, it going inside towards the vagina, so it will stretch all these muscles. So there is always a chance of tear. So overall this whole pelvic floor is supplied by pudendal nerve. It is supplied by pudendal nerve. Pudendal nerve. Okay, it is supplied by pudendal nerve which comes out of sacral 2, 3, 4 of the spinal cord. So this is about pelvic diaphragm. Okay, this is the pelvic floor or pelvic diaphragm. Now we come for the what are the support for uterus, so that we can know what is uterine prolapse. Okay, so uterus. So the uterus is supplied, is supported both sides. There are both sides. It is supported here, both sides. The both sides supported here. Okay, from cervix to the lateral side. So we call it as the cardinal ligament or transverse cervical ligament. This is called as transverse cervical ligament. Transverse cervical ligament, or also called as cardinal ligament. Okay, so and from the side, if you see from the side, you know that now this is the bladder. So uterus is in it. Okay, can you see here? Yeah. So this is the bladder, this is the urinary bladder, this is the uterus. So uterus is giving pressure over the bladder. It is in an anteverted position. Uterus is anteverted position at a 45-degree angle. Okay. So from the back, we need something here, that this is a sacral spine. This is a coccyx and the back here. So we need something to support the uterus, so the uterus remain in anteverted. So we need to put something, some stick here. Okay, we need to put some stick here behind the uterus, so that it don't get straight. Because moment it gets straight, it can prolapse. You know, so uterus don't usually prolapse because it is in a bending position. So lower portion in the vagina, cervix, and the uterus is here like that. So it can prolapse. It will hook. It cannot prolapse. It will hook. It will get stuck. So to have uterine prolapse, there must be, first thing is that it have to become straight, then only it can escape. Okay, so that's why it has to be put in anteverted position always. How? Because there is something here that is giving pressure here, and it making anteversion. So this is from the back of the uterus up to the spine, up to the back spine. So this is called up to the sacrum. Sorry. So that is called uterosacral ligament. So this ligament that is supporting the uterus here is uterosacral ligament. Okay, and so there should be also something from the front. So from the front also, there should be something that is putting. So uterus is anteverted position. Let me draw it. So anteverted position, this is anteversion, okay. And this is the bladder. So there should be something also, there should be something pulling here. Okay, there should be something pulling the uterus. Okay, I don't draw the bladder now. Okay, there should be something pulling here. So pulling is from the cervix. So here there's cervix. So something is from, so something will also, should also pull it to make it anteverted position. So this is going to the pubis, attached to the pubis. So that's why this is called pubo-cervical ligament. Okay. So these are the basic uterine support. So pubocervical ligament from anterior surface. Pubocervical ligament. Okay, pubocervical ligament. Number 1. So pubocervical means pubis to the cervix. It is anteriorly. This is pubocervical ligament. You can imagine. So this is the pubis, pubic symphysis. So this is the anterior side. This is posterior side. So from the posterior side, there is one ligament here, and it is pulling the uterus towards front, making it anteversion. So because of the pulling because of pulling of the cervix here to the pubic symphysis, so pubocervical ligament. This is anterior pulling, and there is also in the back of the uterus there is something pushing here, so that it remains in forward position, anteverted position. That is uterosacral ligament, to the uterus to the sacrum. Okay, and then from the side, these are transverse cervical ligament. So everything is, all these are in pairs, and they are supporting the uterus. So normal position, you know, that is anteverted and anteflexed. So normal, this is the urinary bladder, and this is uterus. Okay, this is uterus, it is urinary bladder. So you can see this is a person is lying down and in a supine position. So you can see this is upright. Alright. So not this in supine position. Okay, forget it. So normal uterus is anteverted, anteflexed. So what is anteverted? If we draw a straight line here, and from the cervix we draw another straight line here. So this is 90 degree. This is called anteversion. And if we join this line to the body of the uterus, here, so this is 120 degree. This is anteflexion. So question comes in the MCQ, normal anteflexion degree is 120, normal anteversion is 90 degree. So again, so if you draw from a line from the vagina here straight, and where it reaches the cervix, the perpendicular line, so this is anteversion. Okay, and if you draw a middle line from the uterus, from the body, middle line, so this is anteflexion. So normal anteflexion is, this is 30 degree more. So 90 plus 30, 120 degree. Okay. So normal, this is anteflexion, and this is anteversion. Okay. So normally the position of the uterus is anteversion and anteflexion. Now again I am telling you, so look here, to have uterine prolapse, first this uterus must come here. Must become straight, then only it can prolapse. Otherwise it cannot prolapse. It will be stuck here. So which ligament plays very important. First thing is that the back ligament, which is always pushing it, that must be weakened. Okay, that's the concept. Please try to understand it. The uterosacral ligament is making the position possible here. Anteversion is because of the uterosacral ligament. This ligament is here like this, stuck here. If it gets weakened, it will become straight. It can prolapse. Now, anteriorly to the pubis, this is also pulled by pubococcygous ligament. Okay? Oh, sorry, not pubocervical ligament. Sorry, pubocervical ligament anteriorly. So this pubocervical ligament, if the force comes down, again, if suppose we remove this pubocervical ligament, what will happen? If we remove this pubocervical ligament, the uterus will go straight, because it is constantly pulled by pubocervical ligament. So if we cut the pubocervical ligament, it will go straight. And what will happen? Then it will prolapse. So these two ligaments you must know. So cause of the uterine prolapse, so that prolapse, okay? These two ligaments are counteracting. This is uterosacral ligament on the back, pubocervical ligament at the front. The sides are transverse cervical ligament. They also have an important role. We'll discuss later on. Next is the etiology. So what relates to uterine prolapse? Why there is uterine prolapse? Okay. So first of all, etiology, age plays a big factor. Age. So with increasing age, this pelvic floor muscles gradually weakens. They becomes less less ability to contract properly. Though these are voluntary muscles, they become gradually weakened. So age is an important factor. After 50 years, after 60 years, as the year progresses, then there is a chance of genital prolapse or uterine prolapse. Now, this prolapse, what we are discussing today about the uterine prolapse, okay, about the uterine prolapse, you have to understand that this is common in those females, those who had a history of pregnancy, those who are multiparous. Because with every pregnancy, these pelvic floor muscles are hit by the fetal head, and during labor it is stretched. So with every pregnancy, with every labor, there is a weakening of pregnancy, weakening of pelvic floor. So if the pelvic floor weakens, now this pelvic floor is holding the uterus. This is holding also the urethra. This pelvic floor is holding the uterus and holding the urethra. Okay, you need to have sufficient strength. If you lose it, it can go down, which we call as prolapse. And remember, this pelvic floor is holding three things. Okay, one for at the front is the urethra, middle is the vagina, back is the anal. Is holding the three like this. So more it is stretched, more it is in stress, more pressure, it can lose up and it can prolapse. Alright? So that's the concept of prolapse. So with increasing age, then history of pregnancies. There is no particular number, so how many pregnancies can lead to uterine prolapse, but it differs from person to person how fit they are. But every pregnancy will lead to some weakness of pelvic muscles. Now there are some down in the number because people are very concerned with their fitness and they do lots of Kegels exercise. So that Kegels exercise should be taught to every patient, every person who is going for pregnancy. Okay, it helps, it works. That is the only exercise which can make this whole pelvic floor strong. You have to voluntarily contract the muscles, hold it as much as you can. So repeat it for 10 times in the morning, 10 times in the noon, afternoon, night. So at least 60-70 times in the whole day, and you can increase gradually the numbers. It will make the pelvic floor really tight and strong in next 6 months. Okay, and that will decrease the incidence of prolapse. So age is there, then I told you history of pregnancies or childbirth, and then stress or heavy exercise, stress or work. So if a person has been pregnant and after delivery she goes back home and immediately starts some heavy job, heavy work, like squatting, like doing some field work. So and means if every time you squat, you are giving pressure to your pelvic exercise, pelvic floor. So if you are doing some work where you have to squat a lot, okay. So if a lady after delivery immediately within 48 hours after delivery or 72 hours, and she starts doing some heavy job where there is a chance of giving a lot of pressure to the pelvic floor, then it can result to weakness of the pelvic floor. So that is why stress, I mean not mental stress, okay, this is stress to, or I say pressure, increased pressure to pelvic floor immediately after delivery or heavy work, there can be cause. So any cases of increased abdominal exercise is increased abdominal pressure that I am discussing about. Whenever there is any case of increased abdominal pressure, when the pressure is very high, so it can after delivery, or is anybody who has 2-3 children, their pelvic floor is always little bit weaker than comparison to another lady who has never been pregnant. Okay, there will be a difference. So, and if she is doing lot of pelvic floor, a lot of exercise in the gym where she has to give she's giving lot of pressure to her pelvic floor, when she is not wearing abdominal belt and other things, and she is not doing it properly, then what can happen, or lifting so much of weight, then also it can distract that pelvic floor. So every time, that's why when you do abdominal exercise or any exercise in the lower limbs, you must wear an abdominal belt, especially when you are in the gym or lifting heavy weights. Okay, so that can protect your pelvic floor. Okay, these are the basic etiology causes. Now, what are the support? Oh, let's try to understand the support now. So, number one support to the uterus is apical support. Apical support. So, what are the apical support here? So, let's draw the uterus. So, this is the uterus. So what are the three ligaments on the top of the uterus? This is the cervix, okay, and this is the cervix, and this is the vagina. So what are the three ligaments? One ligament is from the front, which is pulling the uterus to the front, making it anteverted anteflexion. So that is from the cervix to the pubis. So one is pubo-cervical ligament. Next is the transverse ligament to this transverse cervical ligament. Transverse cervical ligament. And third is the from the back, okay, we know that from the back there is a ligament here on the uterus, that is uterosacral ligament. So this is number 2, and 3 is uterosacral ligament. So when a question of 2 marks come, what are the ligaments in apical support from uterus? What are the ligaments on apical support for uterus? You write these 3 ligaments, 1, 2, 3. They are called apical support. Apical support. So top of the uterus is supporting there. Okay. So this is about apical support. What is the now level 2? This is level 1 support. Okay, level 1. First degree support. So what is the level 2 support? So level 2 support here. So I know that this is little bit complicated, but you should know if I have to treat any patient of prolapse, and which is not so uncommon. So this is the bladder. Okay, this is urinary bladder, and here there is a uterus. Okay, so this is uterus, and what is there behind the uterus is the rectum. So here there is a rectum. Okay, we are still looking at from the side. So between the uterus and the urinary bladder, there is like a curtain. There is a piece of ligament here. Okay, so that is called pubo-cervical ligament. Oh, sorry, what is that called? That is called this is called, yes, it's called pubo-cervical ligament. These are called septum. Okay, these are not ligament, they are called septum. So here is a septum which is differentiating. This is the anterior septum, which is differentiating from the urinary bladder and the uterus. It is from the cervical septum or pubo-cervical septum. So this is the bladder, this is the uterus, and here there is a thin septum, which is demarcating, which is maintaining a disc gap, and as a result they two are separated by septum. Okay, so remember, so this is a septum which is maintaining a good distance between urinary bladder and uterus. Now what will happen if there is a tear in the septum? So what will happen if there is a tear in the septum? Okay, what will happen if there is a tear during any stress or any delivery? So this is a septum, and here on the back there is uterus, on the front there is the urinary bladder. So if there is a tear, what will happen? This urinary bladder will pouch out of it. It will pouch out of it. So when the urinary bladder is coming out of that gap, because there is a tear here, we call it a cystocele. So when you say urinary bladder prolapse, it's not coming through urethral opening. Remember, cystocele means urinary bladder, this septum, which is a gap between the uterus. This is the uterus, and this is the urinary bladder, and there is a septum here. This is a cervical septum. So when there is a tear here, if there is a tear here, suppose if there is a tear here, so what will happen? This urinary bladder will come out of it, and there will be a pouch here. It will come out of it. So this is called as cystocele. So when there is a problem here, it can result in cystocele, because urinary bladder will come out of it. You have to imagine that, okay? So there is another septum here, which is called as rectovaginal septum. In a similar way, there is another septum here, rectovaginal septum. This is called rectovaginal septum. So this is uterus, and this is rectum, and there is a curtain here. This is called rectovaginal septum. So if there is this septum is defect, there is tear, then what will happen? Rectum will come through this septum, and it will come through the septum. So if there is a tear here, what will happen? If there is a tear in the septum, this will come along with this vagina, through the vagina. It comes through the vagina. So it will called as rectocele. So when there is a level 1, all these ligaments are having problem, all getting weakened. What will happen? The uterus will become straight, and there will be uterine prolapse. But if this level 2, these two septum are also defected along with the level 1. Okay, level 1, we know there are 3 ligaments at level 1, which are called apical support. There are 3 ligaments: from the side, transverse cervical; from the front, pubocervical; from the back, uterosacral. So if these ligaments, which is holding the uterus and keeping the uterus in anteflex and antevert, if these ligaments get weakened, it will become straight and come down. Uterine prolapse. Number 1. When there is a defect in apical support. Now when there is a problem in the level 2 support. So what is level 2? These are 2 septums which are differentiating between uterus, urinary bladder, and rectum. So I can make a schematic diagram like this. So from the anterior to the posterior, this is from the anterior to the posterior, this is urinary bladder, this is vagina, and this is rectum, and these are the 2 septums here. This is anterior septum, this is posterior septum. Okay. So when there is a septum defect here, this urinary bladder will come through the vagina. We call that a cystocele. We call this is a cystocele. And when there is a defect in the posterior septum, this is rectovaginal septum. This rectum this whole rectum muscle, this can come through this. Here. We call it a rectocele. Okay. I hope that clears. So this is so sometimes patient may have level 1 apical defect in prolapse. There only uterus is prolapse, but sometimes when there is a severe stress or severe tear, then it can cause level 1 plus level 2. Means means uterine prolapse plus rectocele plus cystocele. It can occur in case when the labor is not properly managed. Look, now when you going some of you going to the hospitals, so we see that when you go to the labor room, the pregnant mother is during the time of labor, she is asked to give pressure when the contraction is starting. Okay, so when the contraction is there, then she should give pressure, bearing down pressure. So if you are giving lot of pressure when there is no contraction, then you can hurt your pelvic floor. Plus, if there is lot of pressure given, you have given oxytocin, you have given lot of pressure, but still cervix is closed, then what will happen? Then again it can tear the pelvic floor. So that mismanagement of labor can lead to 1 plus 2. Okay, this is number 2. When the septums are teared. I hope you can understand now. Level 1 is that apical support. All these 3 ligaments, if they are teared, then the whole uterus from the anteversion, it will go straight and flex and go down, uterine prolapse. So uterine prolapse. Number 2, in the level 2, below the cervix here, okay, at the level here, if there is a defect in the septum, either urinary bladder can bulge inside and come out of the vagina, or rectum can bulge inside and come out of the vagina. So if rectum comes rectocele, urinary bladder comes cystocele. If the lower down here in this septum, if there is a lower down here, what will happen? If there is a lower down defect here, the tear is here, here there is a urethra, then urethra can come out. Urethra can come out, which is called urethrocoele. Which is called as urethrocoele. So when there is a level 2 damage, it can cause 3 problems. One is, this is rectocele. Along with the, when the uterus is prolapsing, when the uterus is going down, rectum is also coming along with it. So uterocele or uterine prolapse, rectocele and cystocele. What else can occur here? Okay, what else can occur here? Okay, look here. So this is uterus. Alright. Now this thing has gone here. It has prolapsed. Okay. So what is happening here? So okay, the whole thing has prolapsed here. It has gone down. So the height, you can see, the height, see, it has gone down here. So there is an empty space created. So what was at the top of this uterus? There are coils of intestine. So these coils of intestine can also prolapse. There are also coils of intestine here also. It can also prolapse. So when the coils of intestine also comes with it, then it can cause enterocele. Then it can cause enterocele. Okay, so then it can cause enterocele. So when there is a level 2 defect, means level 1 plus level 2, how many things can happen? There can be uterine prolapse, there can be rectal prolapse, there can be bladder prolapse, that is cystocele, there can be urethral prolapse, and there can be coils of intestine going out called enterocele. Okay, so many things can happen. Now coming to level 3, okay. So level 3 is that now, this is here the perineal body. So in the perineal body, all the muscles here in the perineum, they are joined. They are joined here. So in the pelvic. So if this this perineal body, it gives support. It gives support. Okay, it gives and support. Okay. So if this perineal body gets weakened, then what will happen? There will be pelvic organ prolapse. So many things will prolapse. There will be whole pelvic organ, everything will be shuttered, closing down. So in the level 3, when there is a level 3 weakness, you can imagine it can be level 1 plus level 2, and sometimes the perineum becomes weakened, and the whole thing can prolapse, whole pelvic floor. Okay, now pelvic floor can prolapse, and as a result, everything will come down, because this is a gutter kind of thing. It's a down with 3 holes. So it can whole prolapse, and everything will be opened. Everything will be open and everything will come down. Okay, that is level 3 prolapse. So along with it, anatomical knowledge, now we can classify the types of prolapse. So what are the types of prolapse? First, okay, let's recap what are the types of prolapse. First prolapse is type of due to defect in apical support. Due to defect in apical support. So what are the things you can get in if there is a defect in apical support? What are the things you can get? You can get uterine prolapse. You can get, what else? You can get, then coming to the, yes, uterine prolapse, and then this uterus can come with vagina, uterovaginal prolapse. Okay, so apical support means if we cut these 3 ligaments, what will happen? If we cut the 3 ligaments supporting the uterus, the whole uterus will go down. So there will be uterine prolapse or uterovaginal prolapse, or there can be enterocele. Everything will happen. So what will happen here? It can also lead to, so this is a defect of type in apical support. Yes, it can also lead to enterocele. And what will happen in defect in level 2? Level 2, we know all the septums. So rectocele, then cystocele, they are common. Plus level 1 can also occur. So that is in the type 2 or defect in level 2, there is a disorder in septum. And when there is a level 3, there is, when the perineal body is, so let me go smooth. So in the level 2, we know rectocele, cystocele are common. Enterocele can occur in level 1 or level 2 both. And in the level 3, defect is everything plus there is, it's below down urethrocoele. Urethrocoele can occur, or pelvic organ prolapse. And plus if there is a level 3, when there is a problem in the pelvic perineal body, it can cause stress urinary incontinence. Okay, so stress urinary incontinence. So what are the clinical features? How the patient will complain? What are the clinical features here? So these are the, now you can understand the anatomy. If you understood the anatomy, you can visualize what happens. Okay, so what are the clinical features here? So clinical features most commonly is that something coming out. They have one line, this is called something coming out. So they will complain of something coming out. Then they can complain of some dragging kind of sensation, because it is going down, it is pulling some weight. So it is kind of dragging sensation, dragging sensations. Then difficulty in urine, passing urine, difficulty in micturition or defecation. Now if someone has a difficulty in micturition or defecation, this is a level 2 defect. Okay, if there is when there is a septal tear. So as we discussed that this is urinary bladder, this is vagina, and this is rectum. So we already discussed that if there is a rectovaginal septum is defective, then this rectum will go out from here. So there will be a problem in defecation here. So if urinary bladder, or because of this anterior septum, the urinary bladder comes here. So let's say this is the urinary bladder, and it is making a pouch here. Okay. Now look what happens. If there is a urinary bladder, a cystocele, there is a pouch here, which is trying to come out of the vagina. So when the urine is going there, there is also urinary retention here. There's always urine collection that can lead to UTI. Because sometimes you may be asked why there is UTI in genital prolapse or cystocele. So why there is UTI? Because of the extra urine collection which is not emptied. So if there is continuous urine collection in this small pocket, that can lead to UTI, urinary tract infection. That is also one thing. Or if the rectum is coming out through the vaginal introitus, there will be this problem in defecation, called rectocele. Alright. So along with that, what other things can happen? So something coming out, dragging sensation, difficulty in micturition, defecation, and yes, there will be UTI and stress incontinence, stress urinary incontinence. So we'll discuss it. Okay, we'll discuss it. Stress urinary incontinence. And what else can happen here? What else can happen here? Here there can be, when there is a uterine prolapse. So when you can imagine here, if there is a uterine prolapse here, when the uterus is coming down, suppose this is the vagina. Okay, this is a vaginal opening. Now uterus has come down. So what will happen? These organs it is coming out of the vagina, so there will be here venous congestion. So it is a small opening through which whole uterus is trying to come out. It is not a case of delivery that everything is wide open here. So this uterus is coming out. So there will be pressure here. It is going out. The uterus is though going down, but it is going down against some resistance. So this resistance will give some pressure here. So there is a continuous pressure. So when there is a continuous pressure, it will occlude some veins here. The veins. It will block some veins here during this continuous pressure here. So there will be venous congestion. So what can happen? There will be venous congestion. There will be increased pressure. Venous congestion due to increased pressure. Okay. So what can happen? Then it can lead to Decubitus ulcer. This is one complication, okay, of genital prolapse. Do remember it comes in MCQs. Okay, sometimes Decubitus ulcer comes also as a short note. So Decubitus ulcer is also called as bed sore. So it is more common in the back. When a patient is lying down for a long time, then continuous friction of the skin and to the bone, okay, it can develop some ulcers at the back. The skin can break. That is pressure sore or bed sore. And we also call it Decubitus ulcer. So Decubitus ulcer can develop also in genital prolapse when there is a continuous pressure and closing the blood vessels in the venous circulation and can result in Decubitus ulcer. Okay, so you have to remember that any sort of Decubitus ulcer, the main criteria of diagnosing Decubitus ulcer is poor circulation, the poor nutrition, and prolonged pressure. So whenever there is prolonged pressure plus poor circulation plus poor nutrition, this 3P will lead to Decubitus ulcer. Okay, so prolonged. Okay, you can see here. So what are the criteria for having Decubitus ulcer? Is that it will be prolonged pressure. There will be poor circulation. And there will be poor nutrition. So all this can lead to Decubitus ulcer. Alright. So these are the clinical features for uterine prolapse. Then what else can happen here? So now next is classification. How do you classify prolapse? So this is normal uterus. Okay, this is normal. Now so uterus has gone down, but still above the cervix. So this is first degree. So this is the vaginal uterus. Okay. So uterus has gone down. There is uterine prolapse, but still the whole body of the uterus is above the cervix, or from the vagina, cervix is above the vaginal uterus. So this is first degree. Then second degree is that. So this is the vaginal opening. So second degree when there is the uterus is here now at the level of cervix. Okay. So cervix is at the vaginal leveling. So cervix is here. This is cervix is at the vaginal level. So this is second degree. When the cervix is at the vaginal level, this is the vaginal uterus. Okay, vaginal opening. When the cervix is here, when the cervix comes to here, then it is the second degree. Then third degree is that when this is the vaginal opening, this is the vaginal level, and third degree almost whole of the vagina has, whole of the uterus has gone down, but the fundus is still up. So fundus is still not out of the vagina. So this is second, this is third degree. And when the fundus also comes out of the vagina, this is fourth degree. So this is also called as fourth degree uterine prolapse, is also called as procedentia. This is called as procedentia. This is also called as procedencia, 4th degree. So question comes, what is procedencia? 1 mark question. So procedencia is a 4th degree uterine prolapse, when the fundus of the uterus also comes out of the vaginal introitus. And remember, it will be always associated with, because what is, if the uterus is going down, the coils of the intestine which are roaming here, they will be also moving, going down. Remember that the coils of the intestine will be also going down. So they will be associated enterocele. But rectocele and cystocele, it depends upon the septum, the side septums, okay, front and behind septum. But uterovaginal prolapse can always happen with enterocele. So what is the surgical treatment here? I will just mention the name of the operations, okay? So when you do the surgical, so another question comes is what is a vault prolapse? Vault prolapse. So vault prolapse most commonly occurs post hysterectomy. So suppose this is the case and you have done vaginal hysterectomy, you have done hysterectomy. So when you do the hysterectomy, when you are doing the hysterectomy, you are cutting the ligaments here. You are cutting the transverse cervical ligament, you are cutting the front ligament, that is pubo-cervical, from the pelvis to the pubo-cervical ligament, you cut it. And you also cut the back uterosacral ligament, you cut it, then only you remove the uterus. You have to cut the 3 ligament and you remove the uterus. Okay? So now you have removed the uterus. So which part is left? Only this part is left. So this. So this part is left. Only this part. You have removed the vagina. You have removed the uterus. This part you have removed in post hysterectomy. So this part is left. You cut all the ligament. So now this vagina, it has got no support because there is no ligament, transverse cervical ligament, you cut it. Uterosacral ligament, you cut it. Front ligament, pubo-cervical, you will cut it. So now what will happen? This is called vault. So this vault can now is left alone without any support, because when you are removing the uterus, you are cutting the 3 ligaments. So this vault can go down. That is called as vault prolapse. So if the question comes in MCQ, commonest cause of vault prolapse is post-hysterectomy. Remember that word, post-hysterectomy. And it comes in the MCQ almost every year. Post-hysterectomy, remember. Why post-hysterectomy? You have to understand the concept, because during hysterectomy, you are cutting the 3 ligaments here. So when you are cutting the 3 ligaments, this whole vault, it is left alone, so it can go down. So that is called vault prolapse. So what is treatment is obviously this surgical, there is no role of medicines here. Okay, so surgical treatment. So treatment here is hysterectomy. Hysterectomy in multiparous women. In multiparous women, it is hysterectomy. But if the woman don't have any child, then you have to save the uterus. Okay, so that's very interesting. How do you save the uterus in a nulliparous or one who don't have child? Okay, so then you can what? You don't cut the uterus here. So what you will do? You will pull the ligament here. So you will pull this 2 ligament here. So you will pull this 2 ligament here, and you will pull the 2 ligament here. Now you want to save the uterus. Why? She cannot be, now once there is uterine prolapse, she cannot become pregnant here again. She cannot have the normal uterus function. But she needs this. Why we need to preserve uterus? So that she can have proper menstrual cycle. We know estrogen and progesterone, importance of estrogen and progesterone. She needs ovulation, whatever she needs menstruation. So to preserve those functions, we need to preserve the uterus. Okay, so what we are doing in young women who are having uterine prolapse, we don't do hysterectomy here. So what we are doing, we are pulling these 2 ligaments, 2 transverse cervical ligament here. So you pull this ligament and you tie a knot here. So when you tie a knot, it is supporting. So you are tying this is uterus, and we pull the transverse cervical ligament from this side, pull the transverse cervical this side, and you are making a knot and is supporting the uterus. It is supporting the uterus here. Okay, that is called Fothergill's operation or Manchester operation. Okay, that is done for young people. Just remember the names. Fothergill or Manchester operation. Manchester operation. So every vaginal hysterectomy or hysterectomy need to be done with this repairs. You cannot just remove the uterus because there are so many tears. So if the anterior septum is defect, when there is cystocele, you have to do anterior colporrhaphy. Anterior colporrhaphy. Or when the posterior septum, rectovaginal septum is teared, you have to repair it, or posterior colporrhaphy. So the hysterectomy will be accompanied by anterior colporrhaphy or posterior colporrhaphy. So it depends upon the type of injury or type of the prolapse, how far it is. Okay. And if it is, as I told you, if it is young, you have to preserve the uterus for menstrual functions. So that is Fothergill's or Manchester operation. So that is about uterine prolapse. Now little bit about stress incontinence. Okay. So because stress incontinence comes as a short note, stress urinary incontinence comes as a short note, comes as a MCQs. It will ask OSCE. So you need to know little basic about stress incontinence. Because this is one of the important complication and clinical feature of genital prolapse. So if your in your exam ask you what is the clinical feature, what is the complication of genital prolapse, you have to say that this is very common stress urinary incontinence. Just in short, so we know that. So this is anterior side, pubis, this coccyx, okay. And there is here the urethral opening. This is the vaginal and this is anal. So anterior side, posterior side, urethra here. Right? So there is a sling here. We remember there is a sling here. It is held by the modified pubo-coccygeus muscle, which is called sphincter urethra. Okay, that is sphincter urethra. So this is supplied by pudendal nerve. So when there is a pudendal nerve problem, if there is a problem in the pudendal nerve, because it comes from S2, S3, S4, there is a problem here or here S3, S4 level, but if there is a problem in the pudendal nerve, or this pelvic floor has weakened, okay, so this pelvic floor has weakened, so what may happen? So this is urinary bladder and the urethra, okay, urinary bladder and urethra. So this pubo-coccygeus muscle or the sling or sphincter urethra is here. It is holding this here. It is holding the here. So when we have to urinate, the physiology of micturition is that this detrusor muscle, this muscle of the bladder, it should contract. When it should contract, this external sphincter which is contracted around the urethra, it should relax. So external urethra relax. So when this part contract, this part relax. Remember that. There's opposite action. So when the urinary bladder contract, this part should relax. So it let the urine pass. So this is the pubo-coccygeus muscle. It's a modified piece of pubo-coccygeus muscle which is called sphincter urethra. So when there is a weakening of pubo-coccygeus muscle or sphincter urethra, or pudendal nerve problem, what will happen? It cannot hold the urethra tight. It cannot hold the urethra tight. So it will become weak. So this is the urethra and it is holding very loose. Now let's say there is a urinary bladder is filling up with urine. So normally it is blocked here, but now there is a pelvic floor weakening. So there can be, so it is little bit loose. So when they will lose, what will happen? So when the person will cough or laugh, there is an increased intra-abdominal pressure. When there is increased intra-abdominal pressure, or you are laughing loud, increased abdominal pressure means little bit pressure. So when there is an increased abdominal pressure to the detrusor muscle, it is contracting little bit from outside. So as a result, some drops of urine can escape. Okay. So spilling out of urine out of the urethra during coughing, during laughing, okay, or during some increased abdominal pressure work, then that's escaping of urine during that time is called stress urinary incontinence. Okay, so when there is a pelvic tear, pelvic floor destruction, damage, or pelvic floor is teared, then also it includes the this sphincter urethra or pubococcygeus muscle. So as a result, this external urethra get loose. So when this external urethra get loose, urine can escape. So most of the time patient is talking to someone or coughing, and she can always feel a drop of urine has escaped. Okay, and that is called stress urinary incontinence. See, this is one of the common complication of genital prolapse or uterine prolapse. Now don't confuse with urge incontinence. Okay, urge incontinence is different. Urge incontinence is when the blood detrusor is hyperactive, when the bladder is hyperactive. Okay, when the bladder is hyperactive, then even little bit of urine can provoke detrusor contraction. So this is going to the where? Spine. Okay, this is going to the spine. This sensation is going to the spine, and from the spine that is parasympathetic impulse is coming. Parasympathetic is coming from the spine, S2, 3, 4. Okay, and it is contracting the detrusor muscle by releasing neurotransmitter called acetylcholine. So when little bit of urine also sends the signal, and there is a detrusor contraction and urine is passing out. So this is urge. Always there is a tendency of passing urine. Okay, little bit of urine is collected and he has to rush to the washroom, and sometimes on the way urine is also spilled out. So there is always an urgency. They cannot hold much urine here. Little bit of urine and there is a detrusor contraction. Little bit of urine, detrusor contraction. So that is a urge incontinence. So don't confuse with stress incontinence. This is called urge incontinence. And this is in some books it is also mentioned as detrusor hyperactivity, or detrusor irritability. So you can understand this is because of release of acetylcholine. So drugs are always, treatment is here always anti-acetylcholine or anticholinergic drugs in urge incontinence. But in stress incontinence, it is basically because of genital prolapse and other smoking and other factors, dietary, very fatty diets. So it involves the pelvic floor muscles. So you have to do Kegels exercise, or if it is more, then you have to go for surgical repair. So treatment is also different in cases of stress incontinence and urge incontinence. Urge incontinence is totally now because of hyper-irritable. Detrusor is not holding, even little bit of urine is collected, detrusor is sending to the spinal cord and making the detrusor contracted by parasympathetic nerve. So sometimes more acetylcholine is secreted. So treatment is anticholinergic here. Treatment is anticholinergic. But if it is stress incontinence, it is because the pelvic floor or pelvic diaphragm weakening. So you have to do Kegels exercise, or you have to surgically repair it if some ligaments or this whole bunch of muscles is teared something. So treatment is also different. So common side effect, or common complication of genital prolapse is stress incontinence. Okay. So what is stress incontinence? Spilling of urine out when there is any sort of laughing or shouting or cough. That is stress incontinence. What is urge incontinence? When there is always an urgency. Even little bit of urine is collected, there is an urgency to pass urine. And she goes there to washroom and she finds only little bit of urine coming out. That is urge incontinence. That is because of detrusor hyperactivity. Detrusor is hyperactive. Okay, this is very common in diabetes. Okay, diabetes people have detrusor instability. That's why diabetic people go to urination very fast, very frequently. It can result in smoking, all these things. And whenever there is detrusor, is even in stress, because in stress also this detrusor can contract more. Okay, any sort of mental stress, anxiety, this can also cause lots of urine coming out, even though frequency is increased, even though there is not so much urine is collected. So that is about genital prolapse and in continuation to stress and urge incontinence. Okay.